So it's almost cliche that American parents want their children to grow up to be doctors and lawyers or to marry doctors and lawyers. Though the prestige and social authority that has been associated with the medical profession is relatively new. In the 18th and 19th centuries, when we're talking about Victorian era, doctors had lower social status. So we have to ask ourselves, what are some of these social processes that now privilege the doctor's perceptions over the patients throughout the 20th century and beyond? Paul Starr in 1982 studied 20th century physicians and noted that they used their status as professionals to increase their incomes, increase their respect, and to gain the exclusive right to determine medical treatments. Formal organizations, professional organizations like the American Medical Association, gave doctors greater control over training doctors of the future. And so one of the effects that this had was it increased exclusivity, increased the educational requirements to become a doctor, and correspondingly restricted access to the education to become a doctor. So, there are a number of medical schools in the United States, but they're not all Harvard, right? And so there's increased prestige that comes with having access to establishments that are granted higher social capital. So just like we talked about how language gave you different social capital, but there was no kind of inferior nature of other language traditions, I mean, the same can be said for education. I mean, in some cases there are, right? In some cases there are schools that give you better education than other schools, but that's not always true, right? There's not something that's so much greater about Harvard's medical school or law school that would elevate them over the medical degree or the law degree that you might get from UNM. So um, it's tying into kind of that degree of social capital and allowing the people that train the people who become doctors and lawyers to determine what's prestigious. That wealth and respect of American doctors is not evident in most other countries' medical communities. In many countries around the world, doctors and patients have very different views. Patients focus on the illness, doctors focus on disease. And so this focus on illness is specifically focusing on how patients feel. That patients' perspectives emphasize the symptoms. They want relief from the symptoms. Emphasizes sensations that they feel. Emphasizes the disability that illness gives them. Emphasize what others might think about them being diagnosed with an illness or expressing traits of an illness, symptoms of an illness, and they think about how that's going to affect their life. They typically take this emic perspective on how illness is affecting them. Doctors, by contrast, focus on disease. They emphasize bodily functions and the physiological processes that lead to the symptoms and sensations that the patient is feeling, predictable bodily responses, the causation, and ways to respond to the causes. So doctors are supposed to focus then on the underlying causes of symptoms as they speak of as disease. So the patient might emphasize that they have a sore throat. The doctor, by contrast, is going to look at potential causes of sore throat and try to rule out certain ones before they prescribe medical treatment. Many parents used to rush to the doctor as soon as their child had a sore throat, demanding antibiotics because it had to be strep, right? Well, antibiotics don't work for viruses, and there are a lot of viral things that can cause sore throats. So, predictably, strep tests have become more and more rapid to the point that there is one they can do in the office in about 10 or 15 minutes that can indicate whether antibiotics are the course of action or not. Now, that's not always, there's a false negative rate with the rapid strep test, which is why they do the cultures overnight in the lab, but it's really getting at that root cause. Taking antibiotics for something viral is not going to help you whatsoever. So the structure of American society upholds the doctor's view as a socially sanctioned one. And this can be problematic. Um, you know, the hospitals, governments, insurance providers, they all recognize the diagnosis of the physician as legitimate. But at the same time, patients who have to live with the symptoms are viewed as lacking the ability to make an official diagnosis or make a prescription, right? So we're seen as not really having knowledge about things, and that can be problematic in some cases. I have a friend who was just recently hospitalized for more than a week. She's been sick for 5 months. She has known something was wrong. She's asked for referrals to see the cardiologist, etc. And she's been told by multiple doctors that it's all in her head, that she just was feeling really, really stressed. And if she would just lower her stress, she would feel better. She wouldn't have this response. Well, it turns out she's got something called post-viral syndrome, where your immune system basically attacks the pericardium, the membrane that surrounds your heart. So she was having real cardiac symptoms. She lost 30 pounds in less than a month because her resting heart rate had shot up to about 140 and would spike to almost 200 when she would lie down. So, a root cause, the necessity for treatment, but something that would have saved her a lot of grief if people had recognized that she, as an individual living in her own body, actually had an idea that something was wrong, right? Doctors miss things. Yes, they have training, but that doesn't mean that other people don't have training or that people don't have the ability to recognize when something's not right in their body. So understanding these different perspectives of doctors and patients and the difference between disease and illness is one major focus of medical anthropology. Healers and patients often have different explanatory models of illness. This has been studied by medical anthropologist Arthur Kleinman, and he's really pointed that it's necessary to consider both the patient and doctor's explanatory models if you want the result to be the most effective medical solutions. So, for example, if we were looking at illness in the Ninjarum in Papua New Guinea, whether that illness was a run-of-the-mill cold or malaria, right? You've got to have an understanding both of what people think causes disease, as well as what doctors know causes disease. And a lot of that is because of the role that the mindset of the patient plays in the patient's own healing. And so, if you've got somebody who insists that sorcery is what's causing their illness, you might have to make a show of appeasing the spirits to block that sorcery before the prescribed medical treatment might work, right? We have to have culturally sensitive knowledges of how patients perceive their own ailments. We've also, though, the Western world, Western medicine is great, fantastic. Things like vaccines, antibiotics, these are revolutionary. These have saved millions of people's lives, if not billions of people's lives. They're great. But we have increasingly medicalized things that may not need medicalization. And so, what do we mean by this term medicalization? Well, it's defined as the process of viewing or treating as a medical concern conditions that were not previously understood as medical problems. So we're going to talk specifically about alcoholism as an example of this, but then we're going to talk about obstetrics as an example of this too. And that's not going to be on the slides. That's like your little extra reward, perhaps, of listening to the lecture. So conditions that aren't recognized as illness can become so through medicalization. And so alcoholism. Between the founding of the US and the early 20th century, excessive alcohol consumption was viewed as a sin or a sign of weak character. By the 1980s, American society, particularly health insurance companies and healthcare providers, had begun to view it as a disease, this disease of addiction. So just think about this vast difference in social meaning between a drunk and a person who suffers from alcoholism? Which one has more, let's say, negative connotations to it? Well, the drunk, absolutely, right? And we typically think of people who use alcohol and other drugs as mechanisms of self medication. We still think of them as weak. Think about how you characterize the homeless. You think of the homeless as people. A lot of people don't, right? The homeless are drug addicts. The homeless are alcoholics. The homeless are lazy. The homeless are, oftentimes veterans. The homeless made a mistake. They didn't know how to save their money. They somehow brought their homelessness on themselves. Now, absolutely, sometimes your individual decisions can result in a negative spiral down, right? But let's just take the notion of alcoholism and or drug addiction and homelessness, right? Where was that weak moral character? Where did that become the issue? Well, maybe it was the very first time they took drugs, but I mean, think about how you self-medicate, right? Because we all do. We definitely all self-medicate. Some of us do it through food. Some of us do it through legal means, including alcohol, right? But some of us have underlying pathways in our brains that make us more prone to addiction. So for some people, you might be able to try heroin one time and not end up addicted. You might be able to binge drink periodically and not end up demonstrating signs of alcoholism. For other people, though, it can just take one incident. So we have to recognize that we've got different perceptions. I mean, and we treat things very differently when we think of it as a medical problem versus a problem with your moral character. So let's think about the medicalization of something like alcoholism, right? Or something like PTSD, right? There are three major reasons that have been suggested for medicalizing the non medical. One of those is financial. So, from a financial perspective, um, there are benefits to be gained from treating a disease versus treating moral failings, right? Pharmaceutical companies, health insurers, they're much better situated to profitably treat disease. Labeling something as a disease then spurs people to seek treatment, spurs people to pursue potentially high cost treatments at a cost to themselves, right? Think about how new drugs come onto the market for things that we didn't even identify as medical problems before, and the vast amounts of fortunes that are to be gained there. If we want to treat something as simply a moral failing, that falls on low pay kind of professions, right? If it's a moral failing, you might try to treat it religiously. Well, except in the case of some of the pastors of some of these huge not medical, evangelical churches, like, I don't know, Joel Austin and stuff, being a religious practitioner is not typically associated with millions of dollars of gain. Neither is being a social worker. Neither's being, many of the public health workers who are out on the ground, getting their hands and feet dirty, helping people. So a lot more money to be gained by having it medicalized. Medicalization also has a social component. It increases the social authority and social standing of doctors. So if we medicalize something, then it's something that will be handled by a prestigious person, right? That if only doctors know how to treat something, then people are going to be more willing to pay money to go see doctors to treat something. If we think of it as an ill of society, again, it falls on the shoulders of characteristically low paid people in these caregiving type roles. There's also an aspect of science. So, given the unparalleled success of the scientific method, Americans are more comfortable seeking scientific solutions to social problems. Science gives us a lot. Absolutely, it does. I mean, Louis Pasteur's germ theory of disease revolutionized medical treatments, right? If we didn't have a germ theory of disease, we wouldn't have antibiotics, we wouldn't have vaccines to treat things like polio, right? What are we all waiting for with coronavirus? A vaccine that works so we can get back to quote unquote normal. Well, here's the depressing aspect. We're never going to get back to normal. Coronavirus, particularly coronavirus in the US, has highlighted a lot of bureaucratic, structural, social problems that we are unfortunately going to be forced to deal with, regardless of how we choose to deal with them. It's highlighted some real problems in how our educational system is structured, highlighted real problems in healthcare and medicine, real problems in financial sectors, right? Like, why did this economic bailout go predominantly to um, major corporations versus into the hands of citizens, right? If you got your $1,200 stimulus payment, probably didn't go that far, probably got sucked up right away with bills, with debt. So, um, yeah, we're seeking scientific solutions, which is all well and great. I mean, I'm first and foremost a scientist. I will espouse the value of science all day, but sometimes we've got to look at what gets highlighted and what science can't fix. And a lot of those things are the social connectedness, the cultural features, the institutionalization of people who are of discrimination, of prejudice, of racism, right? All right, so we'll take a very brief step away from the slides for a moment and talk about the increasing medicalization of obstetrics, right? When you think about pregnancy and delivery, where I grew up, everybody delivered at the hospital. Like, that just was the no-brainer, right? Once you find out that you're pregnant, you find yourself an OB, you visit them for routine prenatal care, you go to the hospital when you show signs of labor, and that way, if something goes wrong, you are right there and they're able to get a C-section and save your lives, right? Well, that is true to some degree. C-sections absolutely have saved lives, but the increasing medicalization of obstetrics in the United States is actually causing mortality, causing fatalities, not saving lives. And part of that is because access to different levels of medical intervention are class specific and race specific. So, what does that mean? Well, Black mothers are 5 times as likely to die during childbirth as white mothers. And it's not simply because they have less access, let's say, to like prenatal care and such. It also has to do with a general belief that they are not capable of like managing their own labor and delivery, and going for increasingly invasive interventions to get the baby out, basically. For those of you who have kids, you recognize that each pregnancy is very, very different, and that you can't really predict how labor is going to go. We have in the United States a 30% elective cesarean rate. That means that these are not C-sections that are medically necessary. These are C-sections that are scheduled for convenience so that your doctor, your OB, can be the one doing the delivery, so that you can time it for when your parents are in town and able to help out, so that you know the specific day of birth. People don't like the unpredictable nature. I mean, the baby's going to come when the baby and your body are ready, not when the due date is, for example. Most first pregnancies go a week or two overdue without any problems whatsoever. So we've increasingly sought out major interventions to make childbirth more convenient. Some people have stated that they didn't want to labor. I mean, sometimes it's because they don't want pain, but because they don't want to mess up their body like that, which is ironic because C-section is major abdominal surgery, and hard to recover from. But we've turned childbirth from being a community women-centered midwifery-centered practice where women are surrounded by other women and coached through and allowed to progress at their own rates to something that is supposed to happen in a timely manner so that if you labor too long, you're rushed in for a C-section. Cesareans are great when necessary, but cesareans are associated with higher infant mortality because of a couple of factors. One of those is that there's a kind of neurological switch almost that's flipped when the baby's passing through the birth canal. The process of labor and delivery has physiological, neurological outcomes for both mother and baby. For baby, it helps to switch that, flip that switch to be able to cope with life outside the womb. So it helps them remember to breathe, for example. It helps them, it's that last final process. It's the end of a cascade of events that makes them ready for life outside of the womb. When babies are taken by C-section, you don't get that last switch. There's a neurological switch that goes on with mothers as well. You are less likely to bleed out if you're allowed to labor and progress at your own rate than if there's intervention to make it speed up, for example. And there's a lot of birth trauma that happens to women where cuts are made, like you're physically incised to open the birth canal, which usually aren't necessary. If you've been cut or torn, you generally get an episiotomy, which is surgical stitching to close it back up. There was a cultural practice of putting in an extra stitch called the husband stitch to make the entrance into the vagina tighter so that it made sex more pleasurable for husbands after women have pushed a 10 centimeter baby, 10 centimeter diameter baby head out of their vagina. A lot of cultural practices that are borderline abusive, but because they happen to women and because they happen in the context of an increasingly medicalized labor and delivery, they're seen as normal. Another reason why babies that are born vaginally die at lower rates than babies born by cesarean is because the passage through the vagina seeds baby's microbiome. And so the vagina is not sterile. The vagina has its own microbiome, just like our gut has its own microbiome. And the initial seeding of a baby's gut microbiome happens because their mouth opens while they're passing through the vagina. So bacteria are introduced into their bodies that are going to set the stage for their healthy microbiome. Babies who are robbed of that process by being born through cesarean aren't seeded. And so instead they get seeded with the microbiome that's present in the hospital air, which, I mean, hospitals are not the places to go to get healthy bacteria, right? They're the places to go to get virulent bacteria because people who have infections are in hospitals. So one way, if you haven't had children yet and you ever find yourselves faced with an impending cesarean section, is to ask them to do a vaginal swab while they're doing the cesarean, and run that vaginal swab in the mouth of the baby after it's been taken out by C-section. That will help to at least introduce the mother's microbiome into the baby. There are also problems with, you can't breastfeed right away after cesarean section because you have to wait until the anesthesia has cleared your system. And so that's also associated with then lower breastfeeding success overall. More mothers who undergo cesarean end up formula feeding than mothers who undergo vaginal births, etc. So, you know, we have this tendency not just with alcoholism, but also with obstetrics to increasingly medicalize things, which then makes it more profitable, right? Doctors make more money, hospitals make more money. Midwives aren't generally in it for the big financial payoff that they're going to get through, you know, increased medical intervention. And we've gone so far as to criminalize midwifery in the United States, both imprisoning midwives, but also imprisoning mothers who seek out midwifery treatment for their own deliveries. All right, so for our third, thinking critically about the body, 50 years ago, alcoholism was considered a moral failing, a behavioral problem. found when people have no strong moral code to live by and something that does bad things for their families and others. Compare this earlier understanding of alcoholism with the now common view that alcoholism is a disease. How do you think that this shift has happened? Right? We need to have this same shift towards things like heroin and methamphetamines, right? And this impacts things like how we perceive people of low socioeconomic status, how we perceive people who are homeless, and then what is kind of our moral obligation when it comes to helping people, quote unquote, fight disease versus helping people overcome, quote unquote, failings of their, morality.